solutions, and essentially, I suppose, looking at what's needed and the factors involved in designing the solutions for maintaining and re-establishing scheduled surgical care in our hospitals, and all the various issues that will go with that. We're very pleased to have our Chief Clinical Officer, Dr. Colm Henry of the HSE, who has had a massive amount of work on his shoulders for the past number of months. And I think it was quite substantial before that, and COVID just added an awful lot more, Colm, I'd imagine. So we really appreciate you giving your time tonight to talk to the surgeons around the country and around the world, indeed, because we have a number of international fellows join us on these webinars as well. So to also just acknowledge David Moore and Debbie McNamara, who are the national co-leads in the clinical programs, who will be giving us their perspective then as well. So as always, we ask everybody to mute their microphones and indeed mute their video, and only the speakers then to turn on their own video and microphone when they're coming on to speak. That makes sure there's no issues with feedback and broadband problems and everything else as well. So you just we will work on that. Essentially, as always, we ask the President to set the scene, I guess, for this webinar and give some thoughts on where the RCSI is with all the issues that are arising, especially around scheduled care. And then at the end, we'll come in on the question and answer session after all the speakers have given their talk to us, and ask everybody to use the chat function on Microsoft Teams to send in your questions or comments, and that'll help generate the discussion at the end of the session. So without any further delay, I'll ask the President to start tonight. Thank you very much. Okay, so I think we're having just slight difficulty there with the President. We'll deal with that over the course. So I just want to introduce then Dr. Colm Henry, the Chief Clinical Officer. Colm, if you might click on your video there and your microphone and give us a quick sound test. All good for you?
Can you hear me there?
Yeah, gotcha. That's great. So Colm, we'll just get you to, I guess, set the scene on what's going on at HSE and the various plans that you guys are thinking of around scheduled surgical care. So I'll open up to you.
Yeah,
thanks.
Eric, if you could put up the slides there. So good evening to everybody, and thank you for the college for the invitation, and to all of you who supported us through the past difficult 15 weeks. There's my slides there. So Eric, I'll just give you a nod when we're switching. So I'm just going to go through where we are now, and it's the people to whom we're accountable, the people, our patients, the board of the HSE and politicians and media and so on, are anxious to see how the light switch can be turned back on as quickly as it was turned off. The problem is we're not turning the switch on to the same room. It's now delivering healthcare in a COVID environment, which carries considerable more risks and uncertainties. And everything I say now is based on two assumptions, Kieran and colleagues. Is that and one is that we will have ongoing low community levels of transmission, and secondly, the social restrictions will continue to ease. And both of those assumptions are fairly big assumptions to make, and we have to allow for the fact that they may not be steady state. So please progress, Eric. Next slide. So there's a lot of talk about shock to the economic system, but this has been an unprecedented shock to healthcare activity, and we know about the impact, and I'll discuss briefly on behaviour, but also the impact of public health decisions designed to break the chain of community transmission, which at one time threatened to overrun us like it had in some the scenes we saw in Bergamo and London and elsewhere. So on the 27th of March, NPHET made a decision among a wide range of social measures to pause non-essential services, including surgery, health procedures and other non-essential health services. We saw a massive drop in presentations to ED, not all of it related to postponement, but to people terrified of coming. A 30% drop in ED attendances. Our rapid access clinics in cancer, which never closed, saw up to 70% drop right across the board. Our trolley car levels were in single figures. And in the community, if you see that graph below, you'd see that one way of measuring GP activity, which is claims for COVID, non-COVID telephone consultations, it's a proxy measure, but a really collapse again in community activity. So next slide, please. So you see here again, AMO, you've got a yellow line there, is that big dip 30-day moving average for acute medical assessment units. People just didn't come, and this was not explained by any disease instance. We know now when you read those case reports beginning to trickle through journals, apart from the projections of excess cancer mortality and so on, you'll see real histories from New York and other places of people with left anterior descending thrombus just not presenting, people who otherwise would have presented early with stroke or heart attack just not coming. And you'll see below in the purple is the number the number of vacant beds there, the 30th of May was 1179. We actually doubled that almost in March and April. Our hospitals were cleared out, left empty, because we expected them to be overrun by COVID illness. Thankfully, that didn't happen, at least not to the degree we expected. Next slide, please. So during the impact of services, and again during this time, we were living with a huge period of huge uncertainty over what would happen. But of course, we were accumulating undelivered care, and I've quantified some of that there in terms of almost 35,000 undelivered cases during the surge period, clinic referrals, and a huge jump in already a significant surgical waiting list. In the UK, the NHS had 725,000 fewer hospital admissions in March and April than expected, and there's been incomplete recovery in admissions. In reintroducing, and to go back to that assumption, it's not, these were switched off, and there were behaviours, as I said, playing into it too. But the reintroduction is into a new environment where anybody could have COVID, and we are aware of the enormous disruptive effect this can have in a vulnerable setting such as healthcare. So the reintroduction involves new ways of working which slow down the pace of work and slow down the flow of work, including infection prevention control measures, the social distancing, which is contentious in terms of distance, the physical space, the staffing, screening going to work, the attrition of staffing who are sick, who have to go off as close contacts, and so on. As I said, the impact on risk of psychology of patients. And to illustrate that, one of our screening programs as a trial now, admittedly during the peak of the pandemic, we sent out 1,000 HPV invitations to women for cervical screening, and about 10% replied. Now, so not surprisingly, those who were healthy but invited to a screening program didn't want to come, but that was playing through to the psychology of other patients too. Next slide, please. Rapid access clinics. Now, I know they're only a small part of cancer presentations, but they're not a bad proxy, given that with the right supports and the right GP referral, this is our means of entry to a rapid pathway for cancer identification and treatment. But we saw a big drop off in presentations to our rapid access clinics of breast, lung, prostate, pigmented lesion. The worst being pigmented lesion, dropping almost 70%. And we know there was one study done in I think Imperial College in London, estimated in excess of 18,000 deaths from cancer. It's too early for us to project forward in this country, but we do know people who don't present as early, delayed presentations, more advanced disease, poorer outcomes, and increased demand on the more high-end and interventional elements of the cancer pathway. Next slide, please. So in terms of our response here, we had to, I'm quoting from Michael Ryan, our compatriot who's on the WHO, which he said the necessity to move trumps perfection. So we did a lot of things we normally never would have done or got away with at speed. That just had to happen. And there was excess done. The private hospitals the capacity was never utilised the way it could have been. There were community assessment hubs set up in order to deal with, we expected hordes of patients with COVID-like disease that really dealt with a fraction of what we expected. And I suppose this is all, we should be thankful for all that. But nevertheless, in parallel with this, we had to set up unscheduled COVID and non-COVID pathways. We had to get patients out of what we thought was a risky hospital setting, out home as quickly as possible. We had to build a critical care capacity from being one of the lowest in Europe to rapidly build up to a capacity that we predicted we would need up to 1,300, but it peaked at much lower numbers. Thankfully, I think at 279 or so critical care beds, always the capacity. We had to set up virtual clinics. During the month of April, there were 80,000 virtual consultations, which is greatly in excess of anything we had done before. And of course, there was a private capacity. At the same time, there was the testing, the contact tracing, and all the other activities we needed to do to watch the illness, to watch its pattern, and to protect healthcare workers and to break transmission. Next slide, please. International experience in terms of building back up. there is no evidence base or and a very limited but evolving experiential based knowledge on how we reintroduce services. And HICWA have done a very helpful review for those of you who have access to NPHET information. There's a couple of reviews on international reintroduction of services, and it is, without going into detail, it is trial and error. It's experimental, and it's cautious, especially in those countries with higher levels of community transmission. And the consistent themes are to maintain capacity for COVID surge, prioritisation of certain care to the detriment of others, gradual phased reintroduction of services, and ongoing infection prevention and control measures and PPE supplies, which fortunately we've secured now to the levels that we need in this country. Next slide, please. And to summarise the measures, I won't go into all the detail. Some of these are slides are a wee bit busy, but there are organisational measures involving staff capacity, and there are physical spacing measures. Those of you in health who work in healthcare will be, I won't go into detail, you know what those mean. And there's patient flow, and they impact in different ways. If you look at the breast screening program, for example, the physical space plays into the waiting rooms, the way the vans are used, and to the sequence of patients going through. Patient flow plays into that too. For colonoscopy, the flow can slow down the pathway through colonoscopy for upwards of 50 or more percent, although systems are getting more adapted to it. So we now have to reintroduce services in the context of a continued threat of a surge, whatever form that might take. And as I said earlier, turning back on services is not as easy as switching them off. Next slide, please. I've quantified here quickly how that meant if we were to adhere to the letter of the law of 80% capacity in a system already stretched for capacity, and we were at 95 to 100% capacity in some hospitals, we would be reducing our beds by an even more critical amount. And that's is something that simply would be very difficult to envisage based on our current capacity in acute hospitals, how we could operate and deliver any kind of safe system. Next slide, please. So in terms of scheduled care, we have to, as with any service, we have to be mindful of the ongoing risks to patients of contracting COVID. And we have to look at an element of care, scheduled care, which has already been disrupted by unscheduled care, and which faces the additional disruption of potential stop-start in a COVID pathway. And the theme, as I said from the beginning, and I have to pay a large acknowledgement to Vida Hamilton here, working with Debbie and others, is the establishment of non-COVID pathways and the promotion, if you like, of partnership hospitals between major centres, at least in urban centres, and private hospitals, which will inform the next stage of negotiation with private hospitals. And minimising the risk to patients. I've outlined those there too, so I won't go into detail on those. Next slide, please. Now, looking for, and this is in terms of how we're going to protect, to increase the capacity for scheduled care and to make sure it faces the minimal disruption, which it already did in terms of unscheduled care, and the additional disruption of the potential of COVID and how that can lead to a disruption in flow and continuity of services. What is most readily available on the shelf, difficult as it has been, is private hospitals. And even though that first deal did not work out in terms of the maximum utilisation of it, in terms of how it was implemented from site to site, it's inescapable that we're going to have to lean into private hospitals. And those negotiations are ongoing. And part of that is a transition agreement. And we will have learned, I hope, from the first cycle, which was brought in at fairly breakneck speed without much planning, and that had to happen because we didn't know what we were going to face at the time. But we'll have learned from that and hopefully try to preserve the integrity of teams, of training, and of services, so that it's less, if you like, elements of care pathways and more integral care pathways transferring. We also have to look at, within each hospital group, of how we can maximise traction in Model 2 hospitals. And I know from talking to Frank Keane, we have to look into the Sláinte care proposal, which is medium to long term and will not provide us with the answers in the short term. There are also new pathways of care. We will have to look at to our consultant workforce and the teams as well, in terms of willingness to work across two sites once we secure a further agreement with private hospitals. a major issue raised by Ronan and his colleagues in the RCSI has been the loss of training opportunities, which must be protected in whatever form the next negotiation brings. The NTPF is always championed by politicians and our political parties, and you'll have noticed that the new Minister of Health is a particular fan of the NTPF. We know from the National Surgery Programme, we know from surgical colleagues the limits of this in terms of what we much prefer to do is build up capacity within our public systems. But nevertheless, we have to use whatever traction we can from the funding given to the NTPF in order to deliver care at a reduced capacity. Next slide, please. So a busy slide, but I'll just go through the headings. So it is a combination of of infection prevention and control, of keeping patients safe, of prioritising services, and all the time watching the pattern of what is a very malign disease, which has an extraordinarily disruptive effect on healthcare settings. Next slide. And those principles here for service introduction: patient need, equity, safety, shared learning, a weighing up of relative risks, and aware that there's an evolving counter risks of delayed treatment, of delayed presentations, and other public health risks, indeed, of people who are staying away from essential services. Next slide, please. As I mentioned, VIDA earlier has been busy working with surgical colleagues and anaesthetic colleagues in issuing interim guidance throughout this crisis, drawn on whatever guidance we could get from international systems, along with input from Debbie McNamara and others. And this has been issued in terms of planned admissions, pre-procedural period, on aerosol generating procedures, and in terms of for planned surgery, for cocooning, for patients before surgery, and for testing at a critical timeline before admission to hospital. Next slide, please. As part of us trying to reintroduce services, we have had to look at clinical prioritisation and working with the programmes and all the subspecialty surgical programmes. We have I identified those services, procedures, and that are of higher priority. And part of our dialogue with those to whom we're accountable is a tough part, which is explaining what we're going to have to do with a lower capacity, and also what we can no longer prioritise. Next slide, please. I mentioned the new ways of working, and I would again acknowledge the work of David Moore, Paddy Kenny, and others who have for a long time advocated for the role of Kappa Hospital elective care, but throughout this crisis it performed additional service in managing traumatic injuries of a lesser severity, and this provides a template for how we use other hospitals who are Kappa is a unique hospital, but Model 2 hospitals and other healthcare facilities that to which we can decant elements of in non-COVID pathways to protect those work. So next slide, please. And in surgical oncology, just to give you an example of the challenges ahead, right through that pathway from presentation through to surgical treatment, we saw a drop, as I said, influence behaviour where people afraid to come, a drop in presentations to GP, a drop in e-referrals, increased waiting lists for non-urgent appointments for urgent colonoscopy where many cancers are diagnosed, public apprehension, and translating to reduced attendance at rapid access clinics and reduced services in terms of oncology. Next slide, please. I'm nearly finished now. So the key challenges restarting, number one by far is capacity. And I've mentioned what we're looking at there. And this isn't something, as I say, we can lean into too readily in terms of sláinte care, which is medium to long term. And it means we have to look around us and see what's most available for this coming autumn and winter, and for what is going to be a 2 or 3 year COVID cycle. We face challenges with resources. As I said, we've faced significant staff attrition rates, at least at the outset of this crisis, when there was a greater impact in acute hospital settings. We face challenges in teams working across other settings once we identify and secure those settings. And we see challenges in terms of testing and screening of staff going to work to ensure that we keep COVID as much as we can out of healthcare settings. This will translate into funding requirements, and we're identifying these different 4 or 5 top priorities for our system right across hospitals and community that we need going into a season of respiratory illness in autumn, where one respiratory illness won't be distinguishable from another. Next slide, please. So I'll skip that one and just go through to the end if that's okay. So the next steps for us is we have there was huge pressure from a country which is hyper attuned, if you like, to screening service, their importance. But for us, it was as if not more important to ensure that the services on which screening relies, namely for those 3 cancer screening programs, are able to be resumed at scale. We're also working with community operations, not immediately in the interests of the group here tonight. And our priority work, I met with the NCP today, is a comprehensive national cancer service plan. Finally, I met with Ronan, and yesterday, and I've spoken to Debbie as well. And our national surgery program, which has been to the forefront of innovation and I suppose prompting us and prodding us in the right direction in the HSE since its own foundation in 2010, we see a central role for them in providing us with a model of care for COVID, for healthcare, for scheduled care in a COVID environment. So thank you for listening, President and colleagues.
Colin, thanks.
Thank you so much. I hope I haven't been muted on this occasion, that people can hear me. But Colin, it really is, I suppose, very reassuring for all of us to know that you have such a detailed overview of the entirety of the problem, and that you're thinking very much along the lines that clinicians think in terms of addressing these problems and looking for the potential solutions. And as I said to you yesterday, we're really on the same side, and anything that the college and the fraternity of surgeons can do to get us through this situation, you know, we have your back on that. And I deeply appreciate also that you've taken very much to heart our view that training remains crucially important throughout this. It's easily forgotten, but that where scheduled care gets outsourced in whatever manner, the training must follow that. And we talked about that last night, and you highlighted it today. So that's very helpful. Can I then ask David Moore to come online and talk to us about some of the really stellar work that our orthopedics colleagues have done in arranging for ambulatory acute orthopedic care to be done outside of the acute general hospitals. Particularly examples are Kappa, and how you've managed the acute trauma network through this COVID crisis and where you see us going. So David.
Thanks, Ronan. Eric, could I have my first slide, please? Yeah, thank you very much for inviting us to contribute to this evening. I hadn't intended, Ronan, I'm very happy to answer any questions on how the acute trauma was dealt with at the height of the pandemic, but most of my thoughts this evening are going to be about the solutions in trauma and orthopedics for scheduled care. Though I can certainly answer questions afterwards if you wish on the acute care. Could I have the next slide, please? So I've just divided my talk up into 2 slides, one on outpatients and one on surgery. And from an outpatient point of view, if you look at the Medical Council list of surgical specialties, I think there's 67. We're one of those, yet we have 12.5% of the waiting list for all outpatients. So our outpatient workload is enormous, and we've had serious limitations on that, like all the other specialties during the restrictions from COVID. We still have problems getting up and running for the same reasons as everyone else, which are those of distancing and space and staffing in our outpatients. Just some of the things I'd like to highlight more to see if people have ideas how we can address them, or maybe we have some ideas how they can be addressed that might be taken up by those who actually invest and spend the money on healthcare. So one of our big problems is imaging and taking, whether that's x-rays. And, you know, we are very, very dependent on, someone turns up with a bone problem, it's nice to see a picture of it. The problem is that a lot of x-ray departments have restricted waiting space, and even if we can manage to see half the number of patients we used to see at an outpatient, we have difficulty getting those patients x-rayed. solutions for that. It's very difficult if you have a patient in front of you and you say, I need an X-ray, and they can't get one on site on the day. You know, it's not really practical to say they can be outsourced for an X-ray and then come back another day for another appointment in a restricted environment. So prioritizing X-ray access for us on clinic days is important. Certainly, we can outsource CT and MRI as necessary. At the same time as we want to get our outpatient clinics up and running, our musculoskeletal physiotherapy colleagues need to get back into action as well. If you can see that our waiting lists at the moment are 72,500 patients, that's in large part due to the fact that over the past 5 or 6 years, the MSK physiotherapists have taken over 130,000 off our waiting list. So it's very important that we can facilitate their return. One of the big problems is physically having enough space. And the suggestion I would have would be that some consideration be given to developing centres in different areas around the country, maybe based on hospital groups or where there are big hospital centres. If there isn't enough room in the hospitals, then maybe we should be considering taking space for all the different surgical or medical disciplines in big unused conference centres that are presently lying idle. I think it is something that we can all avail of, no matter what specialty you're in. I think every surgical group is restricted in getting access to their patients. And really, any of the NTPF solutions that are suggested don't deal with review patients, and obviously it can't, and are very limited in their ability to see new outpatients. The prehabilitation just refers to the fact that this is something we didn't have to necessarily focus on too much in the past, but it's a new area that we have to put some effort into because patients have become deconditioned by sitting around at home during the lockdown period. And that's something that we would ask that facilities and personnel be made available for this. But again, space is required, and otherwise our outcomes are going to be restricted or compromised. Telehealth is something that does well for lots of different specialties. From our point of view, we've been running virtual fracture clinics for some years, but the take-up and our rollout of these during the pandemic has been fantastic. We've been able to get it up and running in most acute hospitals around the country. And what that does is it takes about 40 to 60, but in some respects, in some centres, 70 or 80% of the fracture load away from fracture clinics. And these patients are dealt with all virtually. The problem is we've been able to run them because we've had availability of redeployed staff. And as they are taken back into their normal environment, we're going to lose them and lose the benefits of the trauma assessment clinic with the knock-on effects on our already restricted outpatient capability. The only role really for telehealth for other patients that I would see in orthopedics is maybe for post-op patients, whereby either physiotherapists or advanced nurse practitioners would be in a position to review some of our post-op patients. But an awful lot of our patients actually need to be examined. We need to check and see what's painful, where the restricted joint motion is. And that's something that's very difficult to deliver with telehealth. So I think orthopedics in general is not going to be able to avail a lot of telehealth. If I could just go on to the next slide, please, Erica. So the NTPF is something that everyone comments on, and Colm has mentioned that the current Minister of Health is a fan of it. But, you know, it's hard to see it being touted as a solution, as it has never managed to deal with waiting lists in the past. One of the past presidents of the college, Frank Keane, showed very graphically how as soon as patients were, the waiting list came down after a brief intervention by the NTPF, very rapidly they rose again, because it doesn't really deal with the underlying problem, which is lack of investment in the public system. And that's why we are very strong advocates for, if there is any NTPF funding available, that it be made available to the public system, so that long-term planning can be implemented, and long-term use of theatres, of staffed theatres, be availed of, rather than just at the end of the year or for a brief period say, well, here's a couple of million to try and do a couple of hundred hips. And, you know, it's very difficult to get staff available to do that in the public system. I think that something that we've been arguing, and I haven't heard of it being happening in any centre as yet, which are extended hours and weekend working. I know that there are industrial relation and HR issues associated with this, but we are, as the Minister for Health said recently, in an unprecedented crisis in the healthcare system. And, you know, if all we can do is use previously unsuccessful models that the NTPF has used, we can certainly anticipate that we'll fail to solve the current problems if we use previously unsuccessful systems. Both Ronan and Colm have already referred to the use of standalone hospitals, Kappa being the biggest one that we have, but there are others around the country where really the fact that they can be hopefully kept COVID-free and do not have to compete with acute admissions would facilitate the delivery of planned orthopaedic care. It worries me when, and I understand the prioritization that has been agreed on for patients and the timeliness of their surgery, but it certainly concerns me that, you know, orthopedic patients are usually way down the list in priority, and I understand why that is, but it's very difficult for the patients themselves who are in pain and restricted at home or out of work to understand why they can't get their treatment. And the only way that we can have provide service for so many patients, we've nearly 13,500 patients waiting for operations, is either to do it in standalone hospitals such as Kappa, Croom, Kilcreen, the South Infirmary, or that we deliver it in acute hospitals, but then we're competing with our acute medicine colleagues usually for beds, and we would have to have ring-fence beds. And I understand that that's very difficult to deliver, but I really fear for how far down the pecking order all our patients, such a huge number of patients, I fear how they are going to fall down the pecking order of priority for understandable reasons, but it really is very unfair to that huge number of patients. Another thing we just have some concerns about are a lot of patients after surgery, and it's not just orthopedic patients, but orthopedic patients would be the main users of them, are the rehabilitation facilities or hospitals that are dotted around primarily Dublin, but in some other centres also. At the present, a lot of these beds are being used by post-COVID patients. So that's another block in the way of any scheduled surgery getting up and moving. While we might like to have to plan to commence our discharge planning at pre-assessment clinics, very difficult if one of the significant potential sources of rehabilitation facilities are not available to us. An awful lot of what has already been said is along the lines of what I would have wanted to said, so I'm not going to repeat them. But I do think that unless we're creative, I think that we need to avail of this crisis and come up with some innovative ideas, of which we have plenty, to improve the delivery of care in the future. Otherwise, at present, most orthopedic units are down to about 40 or 50% of their normal capacity, with very little expectation that that's going to increase dramatically in the coming months. I put up pediatric orthopedics and spine there as two kind of special cases whereby pediatric orthopedics kids can only be treated in some centres which are already restricted, not because of the high incidence of COVID amongst the patients, but because of the risk to staff. I'm aware that in one hospital, the current part of the restriction to theatre access for surgeons is because there aren't enough tea room facilities for staff. And it just beggars belief that those type of situations arise and that prevent us treating patients. Spine is the same. Again, there's only a few spine centres around the country. So you have a huge big build-up of what Colm has already referred to as we've been accumulating significant amounts of undelivered care. And spine patients are important because of the potential consequences if their condition deteriorates while on waiting lists. So, Ronan, I haven't really referred at all to the issues of the acute surgery because we were asked to talk about the scheduled surgery, but I'm happy to take any questions. And that's all I have to say. Thank you.
David, it was really putting it in context of what you had achieved with the acute services was by way of introduction. And thank you for your thoughts. Very, very sensible ideas. And again, it just shows the need for leadership. I mean, as clinicians, we have to work with administration, but ensure that we can deliver solutions locally and be flexible. I mean, the idea that you raised that we might be limited by the availability of tea stations and things like that is just not tenable in the current crisis. And so we've got to work with administration, and we've got as surgeons to show leadership. With regard to leadership, I'm very happy to introduce Deborah McNamara, who has shown immense leadership. Debbie, we are all aghast at your work ethic and how you can manage to be a colorectal surgeon on emergency call and get through the amount of work you have in the surgical programs, as well as being a council member. And we're all greatly indebted to you for your efforts. So I'd be very keen to hear what you have to say. And I know some of the figures that you presented to us yesterday will be of interest to our colleagues.
Thank you, President. I have a few slides. Erica, thank you very much. So we've been asked to focus on solutions, and I'm going to cover that under 3 areas. Next slide, please. We've heard a bit about the impact of COVID on our health system, and I'm going to focus particularly on just 2 slides of data relating to surgery. One of the changes that we need to adapt to is delivering surgical care in an environment where COVID is endemic, and it's likely that that will be our circumstance for the next few years. So I'm going to review some Irish data on how we've been doing in identifying COVID in surgical patients. And then finally, just a few slides about possible ways forward in terms of finding a future for surgery in these very difficult times. Next slide, please. This audience will be very familiar with the reductions that they've observed in their own hospitals. And nationally, Dr. Henry has taken us through the data, which is really very significant. As it relates to surgery, over the last 12 weeks, at least 34,000 fewer operations took place. Surgical waiting lists went up by at least 36%. And worryingly, at every stage of the surgical pathway of care, there has been a change with more than 12,000 fewer patients added to waiting lists, indicating that patients aren't flowing through the surgical system, and sadly indicating that there is unmet demand for surgical care in our communities. Next slide, please. Jerry Kelleher kindly provided this slide, and as you can see towards the right of the slide, a very precipitous drop in the number of surgical discharges from our hospitals in the months of March and April of this year, likely also replicated in May and June. To the left is the norm from 2017 on a monthly basis. So you can see that this was really a quite exceptional and precipitous drop. Next slide, please. At the moment, we've been focusing on a number of different phases of the COVID pandemic, and the data that I'm going to show you relates principally to the contain, delay, and lockdown phases when COVID was highly prevalent in society. Next slide, please. During that time, the health service plan was to deliver a COVID pathway and a non-COVID pathway. To a great extent, both pathways were preserved, albeit at much smaller capacity than normal. Next slide, please. So for patients who came to a hospital with a diagnosis of COVID and who had an operation during the 12 weeks to the 18th of May, that was a relatively small number of patients, 200 operations performed based on data from the Healthcare Pricing Office. And 90% of those patients survived, indicating a 10% in-hospital mortality for patients undergoing surgery and who also had a diagnosis of COVID. Clearly a very high mortality, one that we would not be proud of, but nonetheless one that is significantly better than what has been reported in the international literature. Next slide, please. During the same time, it was attempted to maintain non-COVID pathways. And I suppose that brings us to the core of what it is we mean when we talk about a non-COVID pathway. The non-COVID pathway in some hospitals meant that a patient was admitted for scheduled care and a questionnaire about symptoms was taken, and if they answered negatively to all of the questions, they were deemed to be non-COVID and put on a non-COVID pathways. In other hospitals, they might have had a questionnaire and a PCR swab for COVID taken, and if COVID was not detected, they were deemed a non-COVID patient. In some hospitals or some specialties, patients also had a preoperative CT of their thorax. And for some patients, they were admitted for scheduled surgery and no assessment of any sort was taken, but they were admitted through a non-COVID pathway. And of course, we were all learning a great deal about how to cope with COVID in society. No one really knew exactly what pathway was the correct pathway. So we've been working with colleagues to try and study these various pathways to see what is the optimal way to evaluate a patient who is about to have an operation. Next slide, please. So this is focusing on the first 3 phases to the 6th of May, and it's looking at consecutive series of patients. Next slide, please. From the 29th of February to the 5th of May. We defined an operation as something that required a general anesthetic. I know that that might be a controversial diagnosis, controversial way to do so, but we needed certainty in terms of the comparisons. It does include some patients undergoing scheduled and unscheduled care. Every patient had to have a described pathway of care, so we had to know what preoperative testing mechanism was used. We looked at 4 very broad outcomes. Firstly, whether the patient had a PCR swab diagnosing COVID in the 7 days postoperatively. Secondly, if the patient had a clinical diagnosis of COVID in the 7 days postoperatively. And then 2 other outcomes, patients who died within 30 days of their operation and patients who were admitted to the ITU in an unexpected way. Next slide, please. Before presenting this data, it's very important that I emphasize to you the collaborative nature of developing this data series. And I would like to very much acknowledge the colleagues who are listed on the bottom of the slide, who very generously gave their time and series of data to assist with this work, which is ongoing. To date, we've collected more than 3,800 operations, and these were in patients up until the 5th of May. In that cohort of patients undergoing scheduled and unscheduled surgery, 1.3% of patients were diagnosed with COVID in the 7 days postoperatively. We selected 7 days postoperatively because it implies that the patient may well have had their operation while infected with COVID. So the unscheduled pathway does appear to, for the vast majority of patients, eliminate the possibility of having an operation while infected with COVID. 4.5% of patients were referred to the ITU, and the mortality in this group of patients was 0.7% overall. Next slide, please. When we look at the pathways of care, comparing COVID receiving hospitals and non-COVID pathways of care, you can see that the non-COVID pathway of care comprises a bigger group of patients. You can see that we had a greater degree of diagnosis of COVID in patients who were in a COVID receiving pathway of care, by a factor of about 4. And you can see that patients who were on a COVID pathway compared to those on a non-COVID pathway had quite a substantially different death rate, albeit low, but nonetheless different between the two pathways. Next slide, please. When we look at all-cause 30-day mortality, which is a very crude measure, and we look at that stratified by the screening method used to eliminate COVID preoperatively, patients who had a questionnaire only had a mortality of 0.6%. Patients who were screened preoperatively using a questionnaire and a swab, where the swab did not detect COVID, had a mortality of 0.2%. And patients who had no screening had a mortality of 0.9%. And again, just acknowledging my colleagues for this data. Next slide, please. So I think to summarize what we know now, we can say that certainly our current data has many limitations and study of the subject is ongoing. We can say that for patients admitted to our hospitals for scheduled surgery, postoperative diagnosis of COVID within a week of their operation is uncommon at 1.3%. We know that a diagnosis of COVID in the first week post-op is less common for patients on a non-COVID pathway by a factor of about 4. And we know that postoperative mortality is lowest for those patients on a non-COVID pathway, with COVID positive patients who have an operation experiencing a mortality of 10% in our observations, in patients who had a COVID pathway but not COVID infection, experiencing a mortality of 1.5%, and those in non-COVID pathways, 0.1%. Accepting, of course, that the data set is very heterogeneous, includes lots of different types of surgery. So it is difficult to look at this very high level data and make predictions for the future. But nonetheless, I think everyone's experience is that during that period of time, only patients who urgently needed surgery got access to hospital. So I think on that basis, it's fair to assume that these are relatively substantial interventions for significant conditions. Next slide, please. So how do we move forward and develop a scheduled surgical pathway for patients? I think it's clear that there will need to be a COVID pathway, which is our emergency receiving pathway for all patients in public teaching hospitals. And really that should be confined for use for emergency surgery only. That is a higher risk pathway for patients based on our experience of surgical outcomes during the COVID period. It is necessary, therefore, for all patients who are going to undergo scheduled surgery to have a non-COVID pathway. And then the question becomes, how do we define that? Well, we can show in the data that patients who have a negative questionnaire and a PCR swab within 72 hours of their operation in which COVID is not detected are at the lowest risk, provided they are taken through a clean pathway in our hospital where there are ring-fence beds. It's not logical for us to advise a patient to cocoon for 14 days in advance of an operation and then require the patient to be placed in a bed next to a patient who has not had such preparation. So the necessity for surgical patients undergoing significant scheduled operations to cocoon, to have swabs and to answer a questionnaire and to be cared for in a ring-fenced facility is required. Next slide, please. How we deliver that is something that we need to figure out. And it's clear that complex surgery is still best cared for in the public teaching hospital environment. We have spent the last 20 years developing multidisciplinary teams because we believe they deliver the best standard of care to patients undergoing complex surgery. We have spent time developing expertise among colleagues working together in a good system of clinical governance. We believe that delivers the best, safest care. That's the international experience for surgical practice. And we should not depart from that simply because of COVID. And it's likely that that care will need to be continually delivered in Model 3 and Model 4 hospitals where facilities for non-COVID pathways are required. It's equally clear that there are a large number of perhaps less complex, more high volume procedures that can very safely be delivered at other locations. We have some excellent Model 2 hospitals around the country delivering very high volume, safe surgical care to patients. And the NTPF has some success in outsourcing a proportion of these cases, but equally in insourcing such cases to hospitals. Next slide, please. So in designing our future state, I think we need to consider a few principles. It's extremely important that surgical services are accessible to patients all over Ireland. It's not enough to design services that work for just our major cities. We need to make sure that the services are accessible nationally. And for that reason, I think it's essential that each hospital group is required to design solutions that use all of the available hospital capacity in their region. Each hospital group will need to continue to have a location to deliver emergency surgical services. That will be a COVID pathway because it's mixed by virtue of the nature of the admissions for these patients. And some of those patients will be very sick. At the same time, each hospital group must also find a pathway for delivering complex surgical care, including cancer care, but not confined to cancer care. We have many other complex conditions that are not cancerous that equally are life-limiting or improving the quality of life of patients. We believe that high-volume, low-complexity care can be delivered in public hospitals. Some of our Model 2 hospitals are excellent at this, and we think that each hospital group should prioritize identifying a site within the group where they will develop such services. And finally, each hospital group must provide the clinical governance for every patient going through NTPF pathways, thinking carefully about whether an insourcing or an outsourcing solution works best for that group. And that will vary depending on the local availability of facilities in which NTPF care can be provided and whether they are public or private facilities. But it is an important principle that the clinical governance for every patient, irrespective of what hospital they have their care in, should remain with the surgeons in the surgical directorate, and it should remain with the MDT responsible for their care. Introducing, as all the speakers this evening have prioritized, the principle that trainees should follow the patient so that they can experience all types of care. Because if we fail to address the needs of our trainees, we will not have a sustainable surgical service in the future. Next slide, please. In finishing, I'd like to also acknowledge the role of all of the team at NCPS, our clinical advisors and specialty advisors who've worked very hard over the recent period, and to thank Dr. Henry for his collegiality and support in reflecting the importance of maintaining surgery at this very difficult time. Next slide, please. I previously put up our contact details, but please get in touch if we can be of assistance to you. And thank you very much, President.
Debbie, thank you so much for that. It's a very well constructed argument for the solutions or the pathways that you have indicated that we really need to consider. And the difficulties will be to overcome the, I suppose, the inertia that has existed in the health service before when we've seen the need for necessary change. But I believe that COVID has given the opportunity that we can actually press the restart button, but do it in a different way. And as you said, that as was said earlier, we're turning the lights back on, but it's in a different room. So can I thank all three speakers, and perhaps Kieran, you've been managing the questions that have been coming in on the chat function. So maybe you can coordinate the questions.
Thank you, President, and thanks all the speakers. So we've had some interesting comments and questions coming in, and I suppose, but one of the things that struck me as I was listening to all the talks was the, you know, you hear the thing about don't waste a good crisis what should we do differently, and this issue of speed trumps perfection. And so we're trying to avoid maybe going back to our EDs being crowded, trolley waits up high where they are, and yet we seem to be seeing that coming back in again. And Colm, has the HSE thought about maybe, what are the different approaches that maybe they take rather than going back to the old solutions as such? Has any thought been given to those ideas?
Yeah, thank you, Kieran. Just brief bullet points. Of course, we learned a lot during this first phase. And as I said, we developed even closer working relationships with right across professional groupings, not just surgery or primary care too. So in short, clearly, we are going to detail capacity, number one. And number two is public health is just underpinning everything we're doing in the whole span of infection prevention and control. In terms of this coming autumn, winter, apart from capacity, we have to build on the capability of our general practice colleagues to see through episodes of care as much as possible. And to just illustrate the potential challenge ahead is that we'll be facing the usual seasonal respiratory disease, but this time we won't know a respiratory virus, syncytial virus from a flu, from a COVID at the outset. So one of the things we're looking at, and we've had a number of workshops which have been very good with clinical leads, is developing those community hubs that we set up as like field camps for assessment of COVID patients as respiratory hubs, supported by diagnostics, protected diagnostics for GPs. So we've got to support primary care. There's always that argument over when we invest in these things, does it offset real demand in hospitals? But look, if we do nothing, there'll only be one route to take, and that's to an emergency department. So to me, in terms of unscheduled care, it's that big respiratory challenge we see every October, November, but this time it's undifferentiated, and any 1 in 100 could be COVID.
Okay. Does anybody else? I mean, I think, David, you mentioned a couple of interesting ideas and innovations that, not to do the same thing again. And if we just think the NTPF was the standard release valve for the waiting list crisis that would come along, but it was short-lived, and we go back to where we were and probably get worse again, that the investment of the NTPF funding into longer working hours and weekends, that has to be something to push on in terms of policy. And an imperative at this stage.
Yeah, I think whatever about the the extended working hours during the week, I think that may be something that the hospital might have to fund. But whoever funds it, I suppose we're not the people who make that decision. But one of the things we feel that would be of value for the NTPF is that, first of all, there is unused capacity, unfunded capacity in some of the standalone elective hospitals, Kappa included. If you could prioritise funding for that for a year, so that you can employ staff who have this, security for a year. Very difficult for people to turn up for 3 or 4 months. Another thing you could do is use NTPF funding to purchase unused capacity in some of the private hospitals, and use those as kind of an outpost or a satellite for the public hospital, whereby the consultants and the trainees would be able to go look after the patients, and it's just more space. Not think of it as a private hospital just renting it. And then the last option is outsourcing. And not that they don't get good immediate surgical care in outsourcing, but the problem with orthopedic patients is that they're lost, and they're let go free. They're not, after 6 weeks, they're not followed up by a surgeon, and they're somewhat homeless, medically speaking, after that. And that's very unsatisfactory. We're also concerned about people who go to units who don't have the joint register, particularly when joints now have to be followed up pretty much indefinitely in case of any problems with the implants. At the moment, the governance isn't the same if you're in the private system as opposed to the public system. So yeah, I mean, they're just some suggestions that we have.
Yeah, those are, I mean, I think really important points. And Debbie, in terms of all the other surgical specialties, I mean, what sort of work is going on to understand how we should prioritize the various lists? Because one of the comments that came in was that not all time-dependent surgery is cancer surgery. So, how should we go about making sure we get the right priority as opposed to just going with a simple cancer must become first and then nothing else?
Yeah, well, and that's a very important point. And I think we've been fortunate in NCPS to have clinical advisors in a range of specialties, and we've added maxillofacial surgery and plastic surgery this year. So, for example, take the example of urology, where our clinical advisor is Professor Eamon Rogers. Eamon has worked with his colleagues around the country, and the urologists themselves developed the prioritization list based on international best practice and also based on local circumstances. So you can take the example of stone disease, which is a benign condition, but clearly a very important one that can cause sepsis and renal failure for patients if not managed properly. So that is a prioritized condition, although it is a benign condition. Similarly, in the area of otorhinolaryngology, head and neck surgery, our clinical advisor and the specialty society have worked very closely with us. And that was an area that got particular challenges, particularly around diagnostic tests and nasoendoscopy, for example, which is performed in virtually every outpatient prior to COVID, but which is an aerosol generating procedure potentially, and which required quite a lot of in-depth study by our specialists and led by the specialty, the clinical advisor, Professor McCon Walsh and others, to work on solutions. So, for example, in that area, the ENT group are publishing guidance this week. So we are working with each specialty to try to prioritize the conditions, not necessarily the cancers that need treatment, but clearly in an environment of restrained capacity, it's very difficult to make those types of choices because all patients need care.
That's great to hear. I mean, that it's a range of procedures as you're being looked at, not just blocks that are there. Colm, could I ask? I mean, you heard the very clear data that's emerging now around a non-COVID pathway is the safest way for patients and so on, and that the key to that is, I suppose, ring fencing the resources, ring fencing beds that are protecting that COVID pathway, be that in standalone hospitals or in individual hospitals where there's protected resources in those hospitals. If you were to advise surgeons around the country on what they should do with their hospital groups, what sort of approaches should they be making to management at this point to see what solutions could be enacted, and what sort of flexibility surgeons may have to adapt themselves in order to facilitate that happening by maybe leveraging the Model 2s, the Model 3s and other resources that may be within a hospital group region?
Briefly, Kieran, first of all, the holy grail for scheduled surgery has been to protect it from the influence and the disruption of unscheduled care. And you mentioned earlier about not wasting a crisis. This is something we have to do now. But there's a twin disruption, as I mentioned earlier in my talk. It's not just the disruption of unscheduled care, but it's also the disruption of a COVID patient within a scheduled pathway, and how enormously that disruption would be in terms of contact tracing, forced isolation, and what would happen to staff then, and also the disruptive effect of outbreaks in hospital settings and rapid switching off, and the fairly draconian but necessary public health measures to follow. So what I would say to we did all that stuff the first time round. It was necessary, it was rushed, it was unplanned. We had no choice but to do that. Now we have time to plan more, and I would say to surgical colleagues around the country to get in there and own this. What we want to do now is the ideal scenario. What good would really look like here is if surgeons and their teams were able to transfer between Model 4, Model 3, Model 2 hospitals, and if necessary, private hospitals, to bring their teams with it, so that those governance gaps we've seen that have been so criticised in NTPF could be addressed by kind of flexibility, not just of individual surgeons but their teams. And the HSE would support people any way we can to do this. We know the NTPF is unloved, certainly by surgeons largely, but we know also why people, our funders, are fond of it, because it delivers results, albeit short-lived. One of the biggest elements for which it was criticised, as I said, was that disruption of governance. And I think I would urge, if there was one thing I would say to colleagues, is own those local hospital group solutions. maximize the flexibility of your teams as far as possible to ensure that you can transfer that governance between COVID and non-COVID pathways.
Thanks very much. I might ask the President at this point if you wanted to make any observations or comments on the various discussions we've had this evening.
Well, I think overall it's been immensely reassuring to know that we have the leadership at HSE level, Colm and colleagues have shown, but also the support of the clinical programs. And David and their colleagues deserve our immense thanks for their support. And I think it's very gratifying at this point to realize that we have close contacts and a common agenda with our funders in the HSE and the Department of Health, common objectives. And I think it's through the clinical programs that, if you like, the administrative side has come to realize that we're actually on the same mission, that there are no particular hidden agendas. We want safe care for our patients. We want to train the next generation of surgeons, and we want to develop the multidisciplinary care that gives the best results. And those are objectives that I think we all can sign up to. And with goodwill and a common agenda, I am optimistic that, as we've heard, never waste a crisis, but it really does allow us to build the future. It will be tricky, it will be expensive, but I think it will change things for the better, and I sincerely hope it will.
Great, thank you. So, just gone past, coming up to 7:10. I think we can bring this evening's webinar to a close. Just to thank again all the speakers, Colm, Debbie and David, for all their contributions and great discussions there and taking those questions, and the President as always for a very thoughtful reflection on everything that was going on. Remind you, next week we're actually going to focus on the medical legal impact of COVID-19 on surgical services, and we're going to have Miss Margaret O'Donnell, who's a council member in the college and the clinical director in Blackrock Clinic, and has a very strong background in medical legal areas, who give us a surgeon's perspective. And we'll also then have legal input from colleagues from the Medical Protection Society and the Clinical Indemnity Scheme. So that's one to look forward to, I think, next week. So just again, thank everybody for joining in. Thank again all our speakers for their contributions. Thank you for all that sent in the questions and comments on the chat function. Made it very interesting discussion for that. And as always, to thank all the team in Surgical Affairs for pulling together all the organisation of these webinars. And that's it. So having a very nice evening, everybody, and thank you. Bye.